Hello, and welcome to the Guthy-Jackson Charitable Foundation NMOSD Grand Rounds. We welcome everyone in attendance and remind viewers that the Guthy-Jackson Charitable Foundation is proud to be a source of information about NMO and related conditions. The content of the following presentation is based entirely on published data and expert opinion. GJCF is not a clinical provider. It does not offer or represent diagnostic, therapeutic, or clinical care recommendation or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The NMOSD Grand Rounds series has some specific overarching goals. They include to offer a practical summary of latest information on a particular topic. They're designed to emphasize key themes and clinical pearls. They're intentionally inclusive of non-specialist audiences, and each presentation includes a pocket guide at the conclusion of the presentation, which is a highlight reference. Viewers are eligible for continuing medical education activity. The process for CME credit includes visiting the GJCF Education Center using the QR code shown here. Select the session of interest and register, then view the session to fulfill CME credit, and then receive CME certification online. My name is Dr. Michael Yeaman, and I'm delighted today to introduce our speaker. And to do so, I'd like to offer a quote from Dr. Weinshenker. His quote is this: "New diagnostic and relapse criteria will transform NMOSD patient outcomes." We are very delighted to introduce Dr. Brian Weinshenker. He is an emeritus professor of neurology at the Mayo Clinic and currently at the University of Virginia. Brian, thank you so much for being here today, and we look forward to your talk entitled Toward Harmonized Relapse and Severity Adjudication. Thank you so much.
Thank you very much, Michael. It's a pleasure to give a talk on relapses and NMOSD. And I'd like to begin by putting relapses into the context of the broad spectrum of clinical manifestations of NMOSD. And the first thing I'd emphasize is that relapses are really the signature and dominant clinical manifestation, certainly the best recognized clinical manifestation of neuromyelitis optica. Unlike the situation in MS, a condition that very closely resembles and initially was thought to be the diagnosis in patients with NMOSD, disability occurred generally in a progressive phase of disease. We do not see this in NMOSD. Relapses are really the dominant way in which clinical manifestations occur. The most typical manifestations of NMOSD are optic neuritis, transverse myelitis, and the so-called area postrema syndrome, inflammation in the dorsal medulla that presents with nausea, vomiting, and quite often hiccups. There are less typical presentations that are less specific. For example, brainstem syndromes and certain brain syndromes, particularly syndromes that affect the hypothalamus and cause manifestations such as endocrinopathy, eating disorders, narcolepsy. But this is the best understood clinical manifestation of NMO, thought to be due to an immune attack, primarily due to antibodies that cross the blood-brain barrier and interact with aquaporin 4, which is most highly expressed in the optic nerve and spinal cord, which is why we see optic neuritis and myelitis as the predominant manifestations. Water channel dysfunction caused by these antibodies, as opposed to an immune inflammatory attack, may occur in some patients, and there have been some rare reports of posterior reversible encephalopathy syndrome, but this is relatively rare. There may be some downstream consequences of ependymal inflammation. The ependymal cells that line the aqueduct are often inflamed, and we can see inflammation, and this can lead to hydrocephalus. This is a later complication that probably occurs in somewhere under 5% of patients with NMO and is really not due to acute inflammation or relapse. And other manifestations that have been attributed in some studies to NMO, such as cognitive decline, mood disorders, and occasionally encephalopathy, may be due to astrocytopathy. And we know there are pathological indicators of astrocytopathy that have been demonstrated pathologically, but these are much less well-defined. So relapse is the dominant way in which manifestations develop in NMO. And I should mention that when we talk about attacks or exacerbations, we're all talking about the same thing. Relapse is basically a recurrent inflammatory attack of NMO. How common are the various types of attacks? I think the best way to look at this situation is to analyze the results from phase 3 clinical trials, which were prospective and less biased to identifying unusual forms of attacks. And I showed the results from the eculizumab and inebilizumab clinical trials, which did provide a breakdown of the various kinds of events that were seen. And what is clear is that the vast majority of events were either optic neuritis or myelitis. In the largest of these two clinical trials, the inebilizumab trial, there were 20 attacks of optic neuritis, 27 of transverse myelitis, and there were 2 individuals who had brainstem attacks. There were 6 individuals who had combinations of attacks in 2 different neuroanatomic systems, the most common of which is simultaneous myelitis and optic neuritis. The other 2 patients had brainstem and optic neuritis attacks. So this is an important thing to remember. Majority of events, attacks, relapses in neuromyelitis optica are optic neuritis and myelitis. Why are specific criteria necessary to adjudicate NMOSD attacks? Well, it is the primary manifestation. It is the primary endpoint in clinical trials. Relapses are considered a determinant of treatment failure and lead to treatment changes. And in clinical trials, patients contribute only a single relapse. That is because, for ethical reasons, if the patient has experienced a single relapse, they're generally removed from the randomized portion of the clinical trial and often put into an open label observational trial, which of course doesn't count toward the primary adjudication of the clinical trial, the primary result, and regulatory decisions. So because the patient contributes a single attack, we have to be very sure when we adjudicate an attack that it is a real attack. Of course, attacks are important because they often result in changes of disability. We've mentioned that changes in disability do not result in NMO as a result of a progressive phase of the disease. And what has come up now that we've had several successful clinical trials and we have several approved agents, we do want to be able to compare results across trials. And I will tell you why this is very difficult based on existing information, and why we have come to realize that it's very important to harmonize adjudication of attacks across different clinical trials. What difficulties do we have with diagnosis of relapses? Initially, we had thought that should be very easy because attacks are often very severe and dramatic, and we know what they are. But patients in clinical trials are often asked to report their symptoms very early, and we see them at a point when they're not fully developed and the clinical manifestations may not be that clear. Furthermore, we've come across the issue that for some patients who have pre-existing deficits, for example, they're blind in one eye, and they come in with symptoms of eye pain and visual loss in the contralateral eye, the scales that are often used in clinical trials, especially the functional system scores of Kurtzke, give them a very high score because of their pre-existing deficit, and there's very little room for the patients to advance in that score to register that it was in fact an attack. So the scales we use can be problematic in detecting attacks. Patients, and we know this from multiple sclerosis, it occurs probably to a lesser extent in NMO, but it is still a problem, who have pre-existing deficits may become symptomatic when they're exposed to stress or fever. The symptoms may subside in a short period of time. These are called pseudo-exacerbations, and we want to avoid calling these true exacerbations. And with a number of the problems that we have experienced now, we have seen that there is often disagreement in clinical trials between the clinical investigators and the site decisions and the adjudication committee decisions about whether an event is an attack or not. And 30 to 50% of events in clinical trials, there is some discordance between the clinicians whose bias it is to offer the patient's treatment and the adjudication committee whose primary mission and focus is to protect the scientific integrity of the trial. And of course, minimizing the discordance by creating very precise rules for adjudication of clinical trials is ideal. If we look at the experience in the randomized controlled trials conducted of inebilizumab, eculizumab, and sotrelizumab, all were based on having symptoms suggestive of attacks, but the way the clinical signs were objectified and expressed varied. For example, in the eculizumab clinical trial, it was primarily changes in the clinical examination were their objective findings, regardless of how these influenced the functional systems. Whereas in the inebilizumab and sotrelizumab clinical trials, the objective clinical measures were based on changes in the functional system scores. And I've referred to the difficulties that can come up when patients have pre-existing deficits, seeing changes in functional scores, even in situations where one is quite convinced that there has been changes in the clinical examination. Furthermore, the trials differed in the use of MRIs. In the inebilizumab clinical trials, MRIs were performed actually of each neuroanatomic site with each event, and the adjudication committee was allowed to review the MRIs in situations where a clinical threshold of convincing change was not met. In the eculizumab trial, this was not done routinely, but MRI evidence, if it was available, could be considered. And in the sotrelizumab clinical trial, MRI evidence was not considered. So it is possible that a clinical event, which might not have met a clinical threshold, but an MRI abnormality was present, would have been adjudicated as an attack, say in the inebilizumab trial, but the same event, because the clinical findings may have been less clear and an MRI wasn't available, might not have been adjudicated as an attack. So comparison across trials can be difficult. And if you look at the percentage of events which were presented as probable attacks by the investigative site and what percentage of them were rejected by the adjudication committee, in the N-Momentum study, which utilized MRIs, it was only 13.6%, whereas it was 78.6% in the eculizumab study and 50% and 25% in the two Sakura studies of sotrelizumab. And if we look at the data from the appendix of the eculizumab study as to why investigator-determined events were not adjudicated by the adjudication committee, in 80 to 90% of cases, this is because there was insufficient evidence in the neurologic examination, even though an attack may have been suspected. The patient may have had eye pain, may have had some change in visual acuity, but it did not reach the level that investigators could be sure, and perhaps an MRI was not available and an adjudication could not be accomplished. Currently, there is no consistent or accepted method of defining relapses in NMOSD. What potential approaches are available to define or adjudicate a relapse? Firstly, clinical, that we've talked about, which could be exam-based. It could be based on use of scores, taking the exam findings and a level of function, how far the patient could walk, the degree of weakness, using the functional system scores that we use in MS and looking at the change. The second approach is imaging, which basically involves identifying new T2 or gadolinium enhancement, either in new lesions or in existing lesions that now have developed or redeveloped gadolinium enhancement. This is helpful, but not entirely reliable, and there may be some delay in the appearance of these MRI findings. OCT is another method that is being explored, for example, looking at edema in the optic nerve by looking for increase in the retinal nerve fiber layer over a certain threshold, such as 10 microns. This is now being considered in one clinical trial as being helpful or supportive of optic neuritis. Biomarkers are also being considered. The most commonly utilized now is a structural protein of astrocytes, the target of the aquaporin 4 antibody in NMO. The protein is GFAP, which can now be measured not only in spinal fluid, but in serum. Neurofilament light, a measure of axonal injury, is another structural marker of tissue injury. But cytokines, which may change with attacks, for example, IL-6 is something that's being looked at, or a composite thereof. And how can we utilize these? We could either use them as one of the above, or we use clinical, and if the clinical threshold is not convincing, then we do MRI or perhaps consider biomarkers. So various ways in which we could adopt a hybrid approach using all three of these. The inebilizumab study was a particularly unique study as far as endpoints because all patients had MRIs of each neuroanatomic system, and many of the patients had serum GFAP, including at the time of attacks. So I, along with the other investigators and sponsors of the inebilizumab study, did a study of the attack adjudication procedure for inebilizumab. And in this study, there were 43 AC-confirmed investigator-determined attacks. So 84% of the events were confirmed by the adjudication committee. It's interesting to note how often the clinical threshold was not met and MRIs needed to be reviewed. This was in 14 of 43, so about a third of the events that were adjudicated by the adjudication committee. After review of the clinical evidence, it was unclear, and the adjudication committee was given access to the MRIs. New MRI lesions were found in 90% of the attacks, and twofold increase in serum GFAP occurred in 56% of the adjudicated attacks versus 14% of the attacks that were rejected by the AC but had been suspected to be attacks by the investigators. If we look at the sensitivity of these various methods, in 34 patients where there was available MRI and SGFAP data, in 17 of those, the patients had clinical evidence plus MRI plus elevated SGFAP. In 14, there were MRI lesions detected only. In only one patient was there only elevation of GFAP, no MRI change. And interestingly, 2 of the patients who were adjudicated as having attacks had no lesions or elevated SGFAP. So this is interesting for the sensitivity. But, another interesting point that I'll make here is there were 13 patients who had symptoms rejected by the AC, and 4 of those had MRI changes or elevated SGFAP. So one might even suggest that even those that have no objective clinical findings, potentially some of them may have evidence of an attack, and it'll be a bit tricky to utilize these data, but it does point out that this is a relatively rare occurrence. This has led to a debate that was published in the MS journal as to whether MRI of a relevant domain should be performed to confirm whether clinical symptoms represent an attack of NMOSD. And arguing for were Edgar Contenti from Argentina and Dean Wingerchuk from the United States, and against Romain Marinier from France and Bruce Cree from the United States. And I was asked to write the synthesis or commentary, and basically those two groups who did the arguments did a very good job, and I really summarized their viewpoints. And really, I think the synthesis of it at the end is MRI may be very helpful in equivocal cases, and particularly those patients who have severe pre-existing visual loss, where it may be very difficult to determine based on objective signs whether this was an attack, but they get new eye pain. It's probably not essential if the clinical symptoms and signs meet a certain clinical threshold and are unequivocal, especially if the attack is in an area not previously affected by NMO, and pseudo-relapse is less likely. But MRI is not entirely sensitive. Optic nerve imaging is still difficult, and there may be equivocal findings, and there can be other cause for MRI changes, particularly in the brain, such as CNS infection. And feasibility is certainly somewhat of an issue, particularly in some countries that have not ready access to MRI immediately out of the emergency room. When we're comparing clinical versus MRI-defined relapse adjudication, there are advantages and disadvantages of both. A particular advantage for MRI is the fact that it is not susceptible to pseudo-relapses. If we see evidence of clear new inflammation, this is pretty strong objective evidence that it is a true event. And it's also not dependent on any interpretation of measurement scales, such as the functional system scores, and difficulties with that. But it does have some disadvantages. It is dependent on technology. We've talked about imperfect sensitivity, and some patients may be more difficult to image. So all of the reasons why MRI can fail can be true for certain events in NMO, particularly in the optic nerve, a very small structure where good imaging is difficult to get. And there are some possibilities for subjectivity in the interpretation of clinical events and also MRI events. Certainly the clinical relevance, obviously by definition, is stronger if you have objective clinical evidence. For MRI, if it is a very clear change, Likely this is very clinically relevant, but more subtle changes, it may be more difficult to know. So taking into account all these issues, a number of investigators sponsored and conducted under the auspices of the Guthy-Jackson Charitable Foundation undertook a project called DSNR, Diagnosis and Severity of NMOSD Relapses. The goal was to define the process and objective criteria for adjudication of relapses. And the goal, sub-goals were to identify whether an event was or was not a relapse, where it anatomically localized, optic nerves, spinal cord, area postrema, or brainstem and brain. And furthermore, because we felt that many treatments may not only completely eliminate attacks, but may mitigate their severity, it seemed clinically relevant to be able to classify the attack categorically according to severity. It's very complicated comparing severity across optic nerves and spinal cord and area postrema. They're so different, but it seemed relevant to be able to give a categorical rating, mild, moderate, or severe. And we were interested in making whatever we came up with harmonized and universally accessible, implemented using a digital interface, and being applicable for clinical trials or for retrospective analysis in a clinic setting or prospect. So the specific goals, we decided that it was important to concentrate on clinical findings compared to baseline and avoid the use of these functional system scores that created these difficulties based on pre-existing deficits. We focused on elements of the clinical examination that determine decisions. We did not want, and many of the clinical trials had collected a number of different clinical ratings that often were not utilized. We wanted to streamline it and focus on the really decision-making clinical findings. We wanted it to be comprehensive and deal with all potential relapse phenotypes, including brainstem and brain and area postrema, which was very unique to NMOSD. To make it short, because we felt the fewer things that we collect, the fewer bits of information and aspects of the clinical examination was going to improve compliance and attention to detail and precision. We wanted the adjudication to be very consistent and have minimal subjective inputs, such that we were going to develop algorithms that were essentially invisible to the end user decisions. So what the investigator had to do was provide us with the raw data, and then the algorithm would work invisibly to come up with a decision as to whether it wasn't an attack. We wanted to make it sensitive and incorporate MRI, but we felt it should be predominantly clinical. And if a clinical decision could be made, as was the case in the inebilizumab study, based on clinical findings alone, then MRI need not be considered. We wanted to provide this as a real-time result. It would be a supplement to an adjudication committee review. And I've mentioned the types of output that we were looking for, the three: relapse versus no relapse, what is the anatomic location, and what is the relapse severity. And of course, we wanted an instrument that was accessible 24/7 internationally with standard input data. We convened 4 subgroups to examine each of these 4 neuroanatomic systems and propose the aspects of the clinical examination and MRI findings and how these could be assembled into an algorithm. And with the aid of the Guthy-Jackson Foundation and a number of their key personnel, especially Brian Weinshenker, has been really instrumental in putting this together and developed a web-based instrument that we call Relapse Navigator. And I will show you some conceptual and overview slides and one example of one module and how the algorithm works. But essentially, the patients must present with symptoms. This is being traditional in all NMO clinical trials. I don't think that's going to change. And those symptoms suggest one of these 5 modules: optic neuritis, myelitis, area postrema, brainstem, or brain. Now, in some cases, such as optic nerve, if you have monocular visual loss, there's no confusion. But in the case of, say, weakness of a leg or of one side, it could be spinal cord, or it could be brainstem, or it could be brain. And we have certain rules which are part of standard neurology that assist us in starting off with one of these modules. Generally, we default to spinal cord if it's unclear, because spinal cord, as we've mentioned, is the most common or one of the most common attack modules. But if that fails, that is, we do not provide or we do not find adequate evidence that it is a spinal cord attack, then further investigations are done to rule out brain or brainstem. And we either get to a confirmed relapse or not. And if it is a confirmed relapse, localize anatomically and determine the severity. A new baseline is determined, so that could be used for subsequent clinical examinations because we're looking at change in clinical exam compared to baseline. So if we, say, for example, had a patient who had leg weakness and a new sensory level over the torso, this would lead to consideration of possible myelitis. And if it was a new event, new symptoms that the patient didn't experience before, or for example, change in a sensory level compared to baseline, the patient would be eligible for a clinically based adjudication. And if the clinical signs were sufficiently clear, we could establish a diagnosis of a transverse myelitis relapse. But if the clinical threshold was not met, or say, for example, the patient had radicular pain alone and we were suspicious of myelitis, but just as we saw with that eculizumab slide, insufficient clinical evidence, and then the patient would move over to the right and we would look for imaging evidence. Furthermore, if the patient had pre-existing deficit and were concerned about a pseudo-relapse, we would move into this imaging-based side of the algorithm. And if the patient had a new lesion or gadolinium enhancement, if it explained the clinical findings, and if it appeared consistent with NMO, then a diagnosis of transverse myelitis was established. If we did not find that evidence, but the clinical evidence was there, then we would pursue, as I mentioned, brain imaging to determine whether it's a brainstem or brain event. If we contrast Relapse Navigator with how clinical events are adjudicated in multiple sclerosis, compared to the EDSS and functional scores, which were developed for MS, this was developed specifically for NMO. The functional system scores were mainly designed to be a summary of the functional status of patients and how this changed, whereas with Relapse Navigator, we're looking for clinical evidence of change and whether this confirms an attack. The organization of the functional system scores was based on functional groups, which included pyramidal, sensory, cerebellar. Cerebellar is not very relevant to NMO, bladder and bowel, whereas Relapse Navigator is organized according to the neuroanatomic site of relapse: optic nerve, spinal cord, area postrema, really reflecting the kind of events that occur in NMO. The rating hierarchy is primarily based on function, using the functional system scales in MS, whereas with Relapse Navigator, it's primarily exam-oriented. And the evaluation for relapses with BDSS and functional system scores is really clinical only, But with Relapse Navigator, we use clinical findings supplemented when the threshold of clinical findings is insufficient with MRI. We had talked about at some length already the use of functional system scores and the fact that pre-existing deficits may complicate detecting change. This is not the case in Relapse Navigator, where we're using what we called a targeted neurologic deficit approach. We're focusing on the symptoms that brought the patient for evaluation for relapse. And with the EDSS and functional systems, the assessment of brain is quite crude, looking primarily at cognitive function and alertness, level of consciousness, and so forth, whereas Relapse Navigator considers all the various ways in which NMO can affect the brain, including narcolepsy, eating disorders, and so forth. So I'm coming to the end now. Just to summarize some key clinical pearls, about 90% of NMOSD relapses affect the optic nerve and spinal cord. The most common non-optic nerve and spinal cord event is the area postrema syndrome, presenting with intractable nausea, vomiting, and hiccups. For less typical relapses, patients presenting with encephalopathy and so forth, certainly these could be due to NMOs, but it's important to consider other potential causes, especially our patients who are on immunosuppressive medication. Could they have CNS infection? Worsening of pre-existing symptoms can be due to pseudo-relapse, but pseudo-relapse is a diagnosis of exclusion. We're not perfect at doing this, and we should always conduct all the relevant investigations, including MRI, to make sure we're not missing a new inflammatory lesion or a true relapse. While often severe, relapses may present with a spectrum of findings from minimal to severe, particularly in patients presenting early. Their clinical manifestations, their clinical exam may not be severely affected, so one has to keep this in mind. MRI may be very helpful, but does not have perfect sensitivity, and it's particularly helpful in equivocal cases and in those who have pre-existing deficits, such as the patient who develops eye pain and an already blind eye. It could be a new optic neuritis, but without MRI may be very difficult to determine. We've put together a pocket guide relevant to this presentation. I won't spend time on it, but I hope it will be of value to you. And now we'll turn to some questions and answers.
Brian, thank you so much for a great, elegant summary of a very important topic. Much appreciated. We'd like to focus now on a couple of questions, Brian. Let's start with this one. Why are objective clinical signs essential? For example, in a patient with established NMOSD, aren't symptoms suggestive of a relapse sufficient in their specificity to establish a diagnosis?
Yeah, Michael, that's an important question. And I think a lot of clinicians would say in a patient where you're quite certain of the diagnosis, a well-established NMO patient who develops certain symptoms, isn't that sufficient? But we've talked about the issue of pseudo-relapses and the fact that some symptoms may seem to get worse. We also recognize certain symptoms such as paroxysmal tonic spasms that are due to aphatic transmission, which can be a delayed manifestation of a relapse of NMO. And we don't really consider those clinical attacks, or patients who develop increased spasticity. That's really not a clinical attack and wouldn't be reflected by a new inflammatory lesion that we can see on MRI. And as we've talked about, patients contribute a single clinical event generally in a clinical trial. So we have to be sure that we're dealing with what we are trying to prevent with the given treatment. And with most of the anti-inflammatory treatments we have, it's objective evidence of new inflammation in the central nervous system.
Thanks so much, Brian. Let's go to question number 2. The question is, in a patient with a brain syndrome, for example, such as acute confusion, what is the differential diagnosis, and is an MRI essential in this situation?
Right. And unlike monocular visual loss, where I would say the differential diagnosis is very constrained, if the patient presents with acute confusion, we've said that 90% of the attacks are optic nerve and spinal cord. So here we'd be talking about something affecting the brain, and it would sort of by definition be atypical. And whenever things are atypical, we have to think more broadly. We know the commonest cause in all people would be some type of metabolic problem, but certainly in patients with NMO who are on immunosuppressive agents, we'd be concerned about opportunistic infection, which can occur. Certain patterns of MRI findings, for example, longitudinal lesions confined to the corpus callosum would be very, very typical for NMO. Hypothalamic lesions, that would be very suggestive of NMO. But if we saw multiple ring-enhancing lesions throughout the brain, we'd be thinking more about nocardia and think this is not typical for NMO. Or say PML, which is something that we always get concerned about developing, although we may have a somewhat difficult time differentiating them. Generally speaking, we can differentiate them.
Thank you, Brian. A third question is, why not rely exclusively on MRI findings of the optic nerve and spinal cord in patients with suspected optic neuritis to confirm a suspected relapse?
Well, I guess, we think of MRI as being very objective. You look at the MRI, you've got the answer. You could just say, let's dispense with the clinical examination and just do an MRI. But we know that for a very tiny structure of the optic nerve, it can be difficult, particularly in patients who already have some optic atrophy, which might limit, say, for example, OCT. We don't see the increase in retinal nerve fiber layer acutely that we might see in a patient who did not have optic atrophy. Gadolinium enhancement, when it's very subtle, it could be due to some residual enhancement from previous optic neuritis, could be due to artifacts. So for a variety of reasons, MRI is not considered the primary way of adjudicating attacks, optic neuritis attacks or myelitis attacks in NMO.
Thanks for that, Brian. And then another question, how does the use of MRI in NMOSD clinical trials differ from how it's used in multiple sclerosis? For example, in MS, MRI changes are generally not acceptable or sufficient to be considered an endpoint in a phase 3 clinical trial.
Yes, and I think this can be very confusing. In MS, primarily MRI is used to detect silent activity, inflammatory activity of MS, which we know is the dominant way in which inflammatory activity occurs, that is silently. It is primarily a silent disease, or at least for phase 2 clinical trials in MS, this is often the primary outcome. In NMOSD, the way MRI has been used primarily is as objective confirmation of clinically suspected events. So really, we're looking at domain-specific. The patient comes in with eye pain in the right eye. We're looking at the optic nerve on the right to see if there's evidence of objective evidence of inflammation. So it's really targeted and almost to complement the clinical exam. Silent lesions in NMOSD probably occur, but at a much, much lower rate. and is not what we're looking for. We're using it really as an extension of the clinical exam to support suspected inflammation that we see or suspect based on clinical findings.
Brian, another question comes up occasionally, and that is, are there patterns in terms of relapse manifestation associated with different demographic groups? That is, do certain patterns exist in your experience in relapses in younger people versus older people, or in people who have had a longer duration of disease? What are your thoughts on that point?
Thank you, Michael. I think it is an issue that hasn't been adequately studied, but there have been reports that suggest that optic neuritis attacks are relatively more common as the presenting symptoms in younger people and myelitis in older people. That fits with my clinical impression, but I haven't studied that very well, but there have been some reports that suggest that. With regard to brain attacks, there have been reports in pediatric series that a much higher proportion of children compared to adults have brain syndromes with NMO, such as encephalopathy or narcolepsy. I think that fits also with my clinical impression. I don't have a big experience with children, but I've certainly seen a number of them that have brain manifestations. In adults, brain manifestations tend to occur, especially in patients who have pretty severe NMO. And, perhaps this makes some sense because the expression of aquaporin 4 is so much higher in the optic nerve and spinal cord. So to overcome the level of expression and attack even parts of the brain where aquaporin 4 isn't as strongly expressed, you might need more severe disease, perhaps higher titers of antibodies.
For individuals who are on highly effective therapies, the FDA-approved therapies, who do happen to relapse, and I realize that's, generally uncommon, but do you find that their relapses are less severe or in other ways different than they would be in patients who are not on FDA-approved therapies?
I believe that is true. And there have been some data that seem to support that attacks in patients who are on effective therapies tend to be less severe even when they do occur. So that's why it's really important for us to quantitate severity, because this is certainly a clinically relevant and important endpoint.
From your experience, do patients who have relapses versus pseudo-relapses tend to exhibit symptoms in the same anatomic locations as either their onset event or prior relapses? Or do you see, from your experience, they're more a random type of localization?
Yeah, well, Michael, with pseudo relapses, almost by definition, patients will develop these symptoms in areas that have been previously affected. And presumably it's because their threshold of strength or is somewhat compromised, and metabolic factors can influence axonal conduction. Demyelination certainly can do this. It's particularly the case, I think, with MS because you have a viable axons with a lot of demyelination, but demyelination is certainly seen in patients with NMO. For patients who have truly new attacks, we do see this tendency for random occurrence in the optic nerve and spinal cord. They are 90% of the attacks will occur there, but I think it's probably just about as likely that if you've had right optic neuritis, you'll develop left optic neuritis, then redevelop optic neuritis in the right eye. But you do see the occasional patients who will have multiple attacks all targeting the same eye. I don't know that that's anything different than random chance.
Very well. Thanks for that answer, Brian. And then lastly, many patients as well as providers often ask, are there prodrome symptoms or signs to a relapse? And Brian, what's your experience in that regard?
Well, there certainly are antecedent events that can trigger attacks. I think upper respiratory infections and infections in general have an activating effect on the immune system, or for whatever reason, seem to, in some people, lead to an attack. But quite often that is not the case, and they seem to come out of the blue. Otherwise, I've not really recognized any prodrome for attacks.
Brian, we want to thank you so much for your excellent presentation and your excellent answers as well. You're an expert in the field, and we really appreciate your offering your knowledge to us today. Thank you so much. We want to remind everyone that continuing medical education credit is available for this presentation. Please visit the Guthy-Jackson Charitable Foundation Education Center using the QR code shown here. Select the session and register, view the session to fulfill the CME requirements, and then receive the CME certification online. We'd like to remind everyone that the NMOSD Grand Rounds series continues. The next presentation will focus on evidence-based rescue strategies for relapse. All of the access to the NMOSD Grand Rounds, other educational events, presentations, and multimedia resources are available through the Guthy-Jackson Charitable Foundation Education Center. And again, you can use the QR code shown here to access these resources. We want to extend our deep appreciation to Alexion and the AstraZeneca Rare Disease Division for sponsoring the Guthy-Jackson Charitable Foundation NMOSD Grand Rounds series. Many thanks to Alexion and their team. Thank you so much, everyone, for joining us. We hope this is helpful, and we look forward to your attending the next presentation in the NMOSD Grand Rounds series.